Welcome to video series on water and electricity. We know that our compartment. So the intracellular compartment is around 40% and 20% of the water occupies the extracellular compartment. So when there is loss of water from the extracellular compartment, it results in ECF contraction, and this contraction can be isotonic contraction. There is equal loss of sodium and water. Hypotonic contraction when there is more loss of sodium, and hypertonic contraction when there is more loss of water. So the other end of the spectrum, we have fluid accumulation in the extracellular compartment, and this is known as expansion. When there is equal gain of water and sodium in the extracellular compartment, it is known as isotonic expansion. When there is more excess of water, it is known as hypotonic expansion, and there is excess of sodium, it is known as hypertonic expansion. Now let's try to understand the clinical relevance of this ECF contraction and expansion. Here is a 35-year-old female who presents to physician with complaints of diarrhea 5 times per day and vomiting 3 times per day for the past 2 days. On examination, skin is dry with the dry oral mucosa. Her blood pressure is around 110 by 70 mmHg. She is not a known case of diabetes mellitus, hypertension or cardiovascular disease. Let's try to figure out what type of water and electrolyte imbalance is present in this individual. Now, since she is having vomiting and diarrhea, so there is loss of extracellular fluid resulting in contraction. Since there is equal loss of sodium and water, it results in isotonic loss of fluid. Because there is equal loss of sodium and water, so there is no change in plasma sodium concentration, so there is no change in osmolality of extracellular compartment. And because there is equal loss of sodium and water, so there is no fluid shift, and intracellular fluid remains same. So this is a case of isotonic contraction of extracellular fluid due to. Coming to the next case, here is a 56-year-old male brought to emergency department with complaints of severe bouts of diarrhea followed by sudden loss of consciousness. On examination, patient blood pressure is 90 by 60 mmHg, hypotension is there. So a random blood sugar or glucose is also reduced. Serum electrolytes, sodium is decreased, so hyponatremia is there. So potassium is increased, hyperkalemia is there, and apart from that, one characteristic feature is dark pigmentation of the skin. So let's try to understand what type of water and electrolyte disturbance is seen individual. Now, so this is the adrenal gland. So the doctor suspects adrenal insufficiency characterized by decreased aldosterone. So what happens? This is a case of Addison's disease, because one of the clinical feature which supports Addison's disease in this particular case, when it is hyperpigmentation of the skin. So what is happening is, because patient is having both diarrhea and vomiting, so there is fluid loss mainly from the extracellular compartment. So because fluid loss is there, there is also sodium loss along in the vomitus and the diarrheal fluid. Because sodium is lost from the extracellular compartment, when we measure plasma sodium, it decreases, and once the sodium is decreased, osmolality also decreases. Now, because the osmolality decreases here, so there is a shift from water from the extracellular compartment to intracellular compartment, so resulting in hypotonic contraction of extracellular fluid due to Addison's disease. Coming to the next case, Vinite. So here is a 11-year-old boy who presents to pediatrician with complaints of high-grade fever, profuse sweating, malaise or weakness, abdominal pain, headache. Mother gives history that her son developed all these symptoms after consumption of roadside food. On examination, oral temperature is 104 degree Fahrenheit and hepatomegaly is noticed. Let's try to understand what type of electrolyte imbalance is seen in this individual. So all the features of fever, hepatomegaly, consumption of roadside foods are suggestive of typhoid fever, and because of fever, there is what is happening, there is loss of water through excessive sweating, and loss of water because of increased temperature. For every single degree rise in temperature, there occurs nearly 13% loss of water from the extracellular fluid. So once the water is lost, relative sodium concentration in the ECF increases, and this increases the osmolarity. So because the osmolality is increased, so fluid shift occurs from intracellular compartment to extracellular compartment. So this is hypertonic contraction of extracellular fluid due to high grade fever. It can be any, it need not be always typhoid fever. Any high grade fever can result in hypertonic contraction of extracellular. Coming to one more case, here is a 60-year-old male known case of hypertension presents to cardiologist with complaints of difficulty in breathing, swelling around ankles and abdominal wall, bloating sensation of stomach, fatigue, weakness, dizziness. On examination, there is increased heart rate. Echocardiogram reveals a failing heart. What type of water and electrolyte disturbance? So this is a case of congestive cardiac failure. So there is decreased output and there is decreased cardiac output. So decreased blood flow to all the organs. As you all know, it is the heart which carries the oxygenated blood to all the organs. When the cardiac output decreases, so the oxygen delivery to all the different organs decreases. So when this decreases in the lungs, it manifests as difficulty in breathing. So bloating sensation of stomach, weakness of the muscles, overall body weakness, and dizziness because of decreased cardiac output reaching the central nervous system. Now let's try to figure out what water and electrolyte balance is seen in this case. So as we now know, because there is decreased cardiac output, so there is decreased blood flow to all the peripheral tissues. So what is happening is there is volume expansion. So this decreased cardiac output is and decreased ECF volume is sensed by the kidneys, which will activate renin, angiotensin, aldosterone system. So from the previous video, if you have watched, you will get to know that the decreased ECF volume, initial decreased ECF volume which is sensed by the kidney will activate renin, which gets converted to angiotensinogen, which will stimulate conversion of angiotensinogen to angiotensin 1, which gets converted to 2, and this angiotensin 2 will stimulate, it is a vasopressor agent. It will increase the blood pressure which was decreased in the patient, and next is it will stimulate aldosterone secretion by the adrenal cortex, and this will cause increased reabsorption of water and sodium, and this causes ACF expansion. Apart from that, it will also stimulate the antidiuretic hormone, increased water reabsorption, and that is how there occurs ECF volume expansion. So this ECF contains both sodium and potassium. There is isotonic expansion of the extracellular fluid. So because there is equal gain of sodium and water, so there is no change in plasma concentration of sodium, so there is no change in osmolality and no fluid shift. So what will be your probable diagnosis is isotonic expansion of extracellular fluid due to cardiac failure. One more point you need to note is this accumulation of the fluid, it can accumulate in around any organ. It can accumulate around the ankles, around the feet, around the abdominal wall, around the face also. So now this edema, this is known as edema, and this edema is of two types, pitting and non-pitting edema. Now the type of edema you get to see in congestive cardiac failure is pitting edema. That is, when we apply pressure over the edematous region, so you get to see a depression. Now this type of edema is because of accumulation of mainly of sodium and water, which is seen in congestive cardiac failure. Apart from that, it is seen in liver failure, liver cirrhosis, where there occurs decreased protein synthesis, and as you know, proteins maintain the colloidal osmotic pressure. When the colloidal osmotic pressure decreases, water accumulates in the interstitial compartment. Apart from that, in renal failure also, there is no reabsorption of the water. More and more water is getting reabsorbed, and water imbalance occurs when the kidneys fails, and you get to see edema also in last stages of renal failure. Now this pitting edema has to be differentiated from non-pitting edema. So in non-pitting edema is mainly seen in lymphatic obstruction. It's also known as lymphedema. So when we apply pressure over this edematous region, there is no pitting seen. So this is mainly seen in lymphatic obstruction and in severe hypothyroidism called mixed edema. So that is how you have to differentiate between pitting and non-pitting edema. Pitting edema seen in congestive cardiac failure and liver failure. Non-pitting edema seen in lymphatic obstruction and mixed edema. Another case, a 67-year-old female known case of carcinoma, that is small cell carcinoma lung, presents with disorientation, convulsion, loss of consciousness. So lab investigations reveals hyponatremia and decreased osmolarity. So what type of water and electrolyte imbalance is seen in this particular individual suffering from small cell carcinoma? Now, so there occurs the small cell carcinoma lung secretes ADH, antidiuretic hormone, which is normally this antidiuretic hormone is secreted by posterior pituitary gland under the influence of hypothalamus, where the osmoreceptors stimulate change in the water balance is sensed by this osmoreceptors. The osmolality, change in osmolality sensed by these osmoreceptors of hypothalamus, and they stimulate the pituitary gland to produce posterior pituitary gland to produce ADH. Now, in individuals suffering from small cell carcinoma of lung, there occurs ectopic production of antidiuretic hormone, and this will also act on kidney, especially in the collecting duct, and causes increased water retention. So what happens is there occurs accumulation of the fluid in the extracellular compartment. So there is only gain of water. Because there is gain of water in the extracellular compartment, osmolality decreases. Now, so because the osmolality is decreased, there occurs fluid shift from extracellular to intracellular compartment. So this disturbance is known as hypotonic expansion of extracellular fluid due to syndrome of inappropriate secretion of ADH. This is ectopic ADH production secondary to small cell carcinoma lung. So next case, 52-year-old female, known case of chronic asthma on long-term steroid medication, presents with weight gain, sleep disturbance, mood changes. On examination, the blood pressure is high. Lab investigations reveal increased sodium, decreased potassium, increased osmolality, increased blood glucose. Now, this steroid medication, long-term steroid medication, what happens is it mimics the regular glucocorticoid synthesized by the adrenal cortex, and they cause increased reabsorption. They stimulate cortisol and the aldosterone. What happens? Stimulate increased reabsorption. That is the reason why sodium is increased, and aldosterone causes sodium reabsorption and potassium excretion. So potassium is decreased here. Because sodium is increased and sodium is a determinant of ECF volume, the osmolality increases. And as you all know, steroids are hyperglycemic in nature. That's the reason why the blood glucose increases. So this is the adrenal gland, which is divided to cortex and medulla. So cortex, we have three parts: the zona glomerulosa, fasciculata, and reticularis. The glomerulosa produces the mineralocorticoid aldosterone, and the fasciculata produces the glucocorticoids, and the reticularis produces the sex steroids. Okay. So now this is the Cushing's disease, characterized by hyperfunctioning of the adrenal gland. Now here in this case, Vinay, this is an asthmatic patient who is prescribed long-term steroids. So now this person is suffering from Cushingoid features. Now this is used to describe the medication side effects, and it mimics the endogenous conditions of Cushing syndrome. Okay. So what happens here is there is expansion of the extracellular fluid because of gain of sodium. Now this gain of sodium is because of increased cortisol and increased aldosterone, which causes increased reabsorption of sodium. So this increases the osmolality of the extracellular fluid. So what happens? Because the osmolality of ECF is increased, there occurs fluid shift from intracellular compartment to extracellular compartment. So this is a case of hypertonic expansion of ECF due to Cushing-Goid syndrome, because patient is given long-term steroid treatment when the person is suffering from okay. Summarize, these are the disturbances of water and electrolytes. So isotonic contraction, loss of isoosmotic fluid, the condition you can remember is diarrhea. So because there is loss of both sodium and water, there is no change in osmolality and there is no fluid shift. Hypotonic contraction, what happens? There is loss of sodium. Good example is adrenal insufficiency. So there is decreased aldosterone. What happens is decreased aldosterone. So decreased sodium, so osmolality decreases, and because the osmolality decreases, fluid shifts from ECF to ICF. Next is hypertonic contraction characterized by loss of water. Loss of water is seen in fever, excessive sweating, and also in diabetes insipidus. So when water is lost, what happens? The water is lost from extracellular compartment. Sodium concentration increases. So this increases the osmolality, and once osmolality of ECF is increased, fluid shift from intracellular compartment to extracellular compartment. Coming to ECF expansion, when there is isotonic expansion of extracellular fluid, there is equal gain of sodium and water. So there is no change in osmolarity and no fluid shift. Conditions you get to see in hypertension, cardiac failure, and infusion of too much infusion of isotonic sodium saline, what we call as normal saline, also results in isotonic expansion. Then is hypotonic expansion is gain of only water. So when there is increased water in the extracellular fluid, the sodium concentration decreases, osmolality decreases, so fluid shift from extracellular compartment to intracellular compartment. So condition you need to remember is syndrome of inappropriate secretion of ADH secondary to small cell carcinoma lung. So the last one is hypertonic expansion, where there is gain of sodium, mainly seen in Cushing syndrome and Cone syndrome. So there is increased aldosterone and increased glucocorticoids, which will reabsorb sodium. So plasma sodium concentration is high, osmolarity is increased. So ECF osmolarity, when it is increased, so fluid shift from intracellular compartment to extracellular compartment. So this was all about the disturbances in water and electrolytes and clinical relevance. Stay tuned for more videos on biochemistry, easy learning of biochemistry topics. Happy learning. If you like the video, please do like, share and subscribe. Thank you.